just to make sure. So I'll let Marissa check on that to make sure. Okay, good. So Cerevastatin was a Baycol, which was put on the market. And the problem with Cerevastatin was that actually it was really the same side effects that we saw with the other drugs. But one of the big things we saw was that, in particular, it was producing rhabdomyolysis, which we'll talk about. And the extent of rhabdomyolysis was much more, this drug seemed to be much more potent, and the chance of developing rhabdomyolysis seemed to be more of an issue. So from a standpoint of that, that was taken off, and it really didn't affect us very much because we had all of these other statins that were out here. And all of these other statins were, hold on a second. I just muted you briefly while one of the dogs was going out. That was Barney. That was Wacko. So as my next door neighbor kids about him, he's a rat terrorist. So he's not a rat terrier. They just call him a rat terrorist. So because he terrorizes the other dogs, he thinks everybody wants to play with him. But Cerevastatin, basically, when it came out, it was really a Me Too drug. It was acting on the statins, and basically, as a result of it acting on the statins, or acting the same way as the statins, it was one of those things that there was really no need for us to have it, and there was more chance of side effects. Other drugs were safer. So as a result of that, and mainly because of the number of patients that were developing rhabdomyolysis, it was pulled off the market. But again, we had plenty of other statins that were available, so it wasn't like it was the only drug out there. And so you'll see that all these other statins have very similar actions among themselves. The mechanism that we see with these statins are basically all of the statins do the same thing. What they're going to do is they're going to competitively inhibit HMG co-reductase. And this enzyme is important because this is actually the rate-limiting enzyme for cholesterol synthesis. When we talk about a rate-limiting enzyme, this is basically the step in the synthesis that is pretty much we have feedback. So as cholesterol builds up, it usually shuts off the production of more cholesterol. So the rate-limiting basically controls the rate of synthesis. Okay. All right. So now it's going to be an interesting thing because, and I've got a video for you guys for when we go to break, there is an interesting scenario with a lot of these drugs, just like what I talked about yesterday. So what's going to happen is these HMG co-reductase inhibitors, the statins, they actually will act in the liver to decrease cholesterol biosynthesis in the liver. Okay. So the liver cells are needing cholesterol. They're needing cholesterol to do a number of things, make steroids, make compounds that are used for phospholipids and for various other things. So we need cholesterol. So what happens is when these drugs shut down the synthesis of cholesterol, what happens is cholesterol levels drop, and the and as a result, cholesterol and LDL levels drop. So what happens is that the hepatic LDL receptors, which is what we talked about yesterday, they're sitting there going, we need more cholesterol. So, and there's less cholesterol there. So they actually regulate. So the body senses that there may not be enough cholesterol in the hepatic liver cells. So what it does is it puts these LDL receptors out there. These LDL receptors upregulate, and the LDL receptors will trap LDL from the blood. And so what will happen is these LDL receptors will start increasing the uptake of the circulating LDL from the blood and bringing it into the liver cells so they can use it to make bile and all the other stuff. Okay. So when, again, as I said yesterday, what's literally happening is that when we have excessive cholesterol and LDLs floating around in our bloodstream, they can attach or attack the endothelial cells and cause atherosclerotic plaques. However, when we remove those so that the liver cells start taking them up into the liver and start synthesizing various components, then what's going to happen is we reduce the amount of cholesterol and LDL in the bloodstream. And basically what we do is we take it into cells. So it's not in the bloodstream, then it can't really attack our blood vessels, okay? Now, interestingly, once these receptors get upregulated, they typically stay upregulated for a while. I mean, the half-life of these receptors is about 15 to 20 hours. So once they start getting upregulated, those LDL receptors stay up there. So that gives us a prolonged efficacy of these particular drugs. So the net effect is that they shut down the synthesis of cholesterol. So the liver cells say, we need more cholesterol, so we reach out and get it out of the blood. We take it out of the blood so it can't stick to the blood vessel walls, and basically gets brought into the liver cells and it's being used for making various things that we use it for. So yesterday we talked about the bile acid sequestrants. So they reduced the bile salts, and when they took the bile salts out, that took the cholesterol out. And so again, what had to happen is when the cholesterol levels dropped, the LDL receptors had to be upregulated to bring in more cholesterol so that you could make more bile and the other components there. Now, these statins, interestingly, we know that their main mechanism is to reduce cholesterol, and through the mechanism I've just told you. But these statins also have some other properties which are important. Help with regard to treating atherosclerosis. Statins, they tend to be thrombotic. So we know by reducing cholesterol that we remove the damage to the plaques, but we also, they seem to have some other actions that mean that somehow they inhibit clot forming. They also seem to have antiplatelet actions, which basically means that they seem to inhibit the ability of platelets to stick to each other. Another thing is they have antioxidant actions. So what that means is that we're not generating free radicals, or they're reducing the free radical generation. And we know free radical generation is one of the things that can damage the blood vessel wall and develop these plaques. And there were some interesting studies, and actually Merck benefited from these because there were some studies done when these statins first came out. And they made, from a scientific standpoint, they were great because they demonstrated that people that had atherosclerosis, that one of the things that happened is if they were on these statins for a while, that literally their blood vessels improved and healed. So it actually, the plaques and everything that had developed seemed to regress. So there was good evidence that it could, a lot of drugs, we just want it to stop going forward, stop the disease from progressing. But there was actually some studies where that they showed that the blood vessels returned back to the normal state, and that could occur in about a year. So one of the things that was occurring was basically that people started saying, hey, not only do these statins prevent additional or prevent further damage, but they actually seem to help reverse the damage. And that was an interesting thing, and Merck really benefited because they had the first statin that was out there, I think, and their stock really jumped up, which was another reason why everybody jumped on the statin bandwagon. Everybody wanted, the different companies wanted to have statins because of these studies that were showing that, hey, these drugs actually not only stop progression of the disease, but they seem to almost return the blood vessel back to the pre-disease state. So that was an issue there. So clinically what we see, the statins all produce a pretty good reduction. Now, let me mention to you that years ago, not too awful long ago, we always measured cholesterol because the cholesterol gave us an indication of the cholesterol circulating around in our blood, or the fats circulating in our blood. It was harder to measure LDL. Okay, So as a result of that, a lot of times what they do is they pull your cholesterol and then they would send their LDL off, and they actually back calculated. They could measure a couple of other things and they back calculated. But technology has improved to the point where that we now can measure LDL directly and we can get a pretty quick result. So now we focus on the LDL. Used to, if your cholesterol was elevated, we would then tell you to get your LDL evaluated. And the LDL seems to be the most damaging of the lipids. So what we found is with the statins in clinical studies that number one is that we saw a reduction in the LDL in people that were taking statins by 20 to 40%, which is pretty significant. Okay. Some of that's dose related. Some of that is, maybe one statin being a little bit more potent than the other. Not only did we see a reduction in LDL, but the good cholesterol actually went up. Now, the statins, in clinical studies, they showed about a 13% increase in HDL, which was pretty good. In real life, we may not quite see that much, but we still see, an increase. And as I said earlier, there was a reduction in the lesion progression. So basically, the lesions didn't continue to develop. So that was pretty significant from a standpoint of our, of what we're seeing with regard to using these drugs. Now, here's a chart. I want to do a little exercise with you on this chart, but let me sort of move this Zoom thing here. Okay, so if you look at across the top here, you can see I have atorvastatin, simvastatin, lovastatin, pravastatin, fluvastatin, and then rosuvastatin, which was actually pulled off the market. And this is the dosages that are available. So you see atorvastatin is, we have a 10, 20, 40, and 80 milligram. Fluvastatin, we have a 40 and 80 milligram. One of the reasons that people like to use atorvastatin was because there was so many dosages. Whereas if you were using pravastatin or fluvastatin, you had a 20 or 40 milligram. And so if you wanted to do a 30 milligram, then you did a 20 and a half a tab. So that sort of thing. If you wanted to do 10 milligrams, you broke a 20 milligram in half. So the 10, 20, the four different dosages, or with atorvastatin and simvastatin, made them very popular. But here's what you see is, so as far as if you look on the right-hand side of the chart over here, what you actually see is that the reduction in total cholesterol, basically you see at the lowest dose of these drugs, of most of these drugs, you got about a 22%. The next dose was minus 27, so we got a 27% reduction. And then, so you saw an increasing reduction in total cholesterol, and then we saw the same thing with LDL, and then we saw the HDL. In some of the clinical studies, they showed about 13% increase. When you actually saw the statins, it really we see it close to about a 4 to 8% increase. So it's a significant increase, which is good. But one of the things is it's not quite as good as some of the other drugs we have for increasing your HDL, which is the good cholesterol. So, but we did see that it was pretty standard for most of the statins in the real world. We got about a 4 to 8% increase. Okay. All right. So if I wanted to get a, let's say roughly a 30 to 35% decrease in LDL, which drug would I choose? So we want to get the LDL response around this percentage here. So we know that 10 milligrams of atorvastatin will do it, 20 milligrams of simvastatin, 40 milligrams of either lovastatin or pravastatin, 80 milligrams of fluvastatin, and 0.4 milligrams. So if I wanted to get about a 30 to 34%, 30 to 35%, which drug would you choose? This is sort of a clinical decision. Okay, so several of you pick atorvastatin. Okay. All right. So let's talk about it. Which one do which one of these would I use? The reality of it is actually I could use any of them. 10 milligrams of atorvastatin, 20 milligrams of simvastatin, 40 milligrams of lovastatin or pravastatin, 80 milligrams of fluvastatin, or zero point 0.4 milligrams of ceruvastatin. Okay. Now let's think about it. So, one issue might simply be what comes down to it could be cost. Another could be which is on the formulary, but any of those could do it. But here's what I want to point out. Probably the best choice would be the atorvastatin or the simvastatin. And the reason for that is, and one of you did actually made a comment about it, Kirsten and a couple of the others, Brady, you guys gave good rationale. The thing about it is I could start with 10 milligrams and I've got 20, 40, 80 milligrams. So I've got a good way to go up. If I don't get that 34%, 35% decrease, I could up the dose. And I've got a wider range to cover. Simvastatin, with atorvastatin, I've got 4 more dosages that I could go up on. With simvastatin, I could go up, I've got 2 other higher dosages without breaking tablets or anything. But with pravastatin, fluvastatin, I'm at the top of the dose response curve, or really at the top of the dosage level, so that doesn't give me very much leeway. Some people jump at 0.4 milligrams. Now, you guys know that ceruvastatin was pulled off the market. But some students, if I didn't put the drugs up there and just put drug A, B, C, D, and E, some people would jump at 0.4 thinking, okay, it only takes 0.4 of a milligram to get 34% decrease. But one of the things, and this is what literally happened with ceruvastatin, is that the 0.4 milligrams may have taken less drug, since you're looking at 0.4 of a milligram versus 10 milligrams of something else. Or it takes a 100-fold greater dose of pravastatin or lovastatin to get this effect. But the sad part about it was the 0.4 milligrams was we don't have any additional higher dosages. But the other thing that we have is that I don't have a lot of although I may have a very potent drug, I may have more side effects, and that's exactly what happened with ceruvastatin. In fact, ceruvastatin, the company that put this out, I was an expert witness on some of these cases against the company. So there's my disclaimer. But they actually talked about trying to market a 0.8 and a 1.2 milligram dose. And the reason for that is they did not anticipate anyone ever using those dosages, but they wanted to market it so that clinicians would not think that was the highest dose. So it would make clinicians think that they were in the middle of the dose response curve. So, but with this one here, the point becomes many times your choice, and this could happen with your SSRIs. Many times the choice may be an issue of cost or what's on their formulary. Sometimes there may be differences. We do have some individuals that, for example, atorvastatin just doesn't work in them, but simvastatin does. Or there may be some issues like, for example, drug metabolism. Pravastatin really marketed their one of the things they marketed was that their drug, pravastatin, that company that put it out, was marketing it that their drug did not have as many drug interactions through the cytochrome P450 system. So there's a number of reasons for this, but the main thing I wanted to show you guys with this table is that pretty much we can get this drop using the drugs. Now, obviously, pravastatin, fluvastatin, we're probably at the top with this. Now, if we maybe half the pill or double the pills, we maybe could get there. But we see a lot of atorvastatin and simvastatin used because we can go up, get a little bit higher of that. The dose responses don't plateau out there. All right. Now, with these statins, and again, one of the things is a lot of people think the statins are very, very, very safe. We have a lot of people on statins. I bet a majority of your patients if you've got adult patients, I bet a majority of them actually are on statins. And so that's one of the things that you need to think about. But they were, I mean, a lot of people thought they're extremely safe, to the extent that 2 or 3 different times, even I think a year or two, that some of the companies have tried to move them to over-the-counter use, citing their safety and the number of people on the with everything. So it's a big concern that I would be concerned about having statins go over the counter. I think there are some serious side effects that could be associated with them. And I still think that, if they go over the counter, one of the things, if you're going to get your prescription, like I'm on a statin, and one of the things that, I've been taking the statins for a long time, but my doctor will always make me come and get bloods. Of course, I'm a pharmacologist and I know what these statins can do, but there will be, my doctor is, routinely requires at least annually. But sometimes if he were to change a dose or something back early on, then he would want a dose, he'd want to run labs in 6 months. So the point would be is that if they were over the counter, one of the big things that could happen is going to be that these drugs people could develop some of these side effects and would not have the clinical monitoring. If it's over the counter, it's not under the supervision of a healthcare professional. And so therefore, you would have to see your doctor, and they possibly could say, make sure you get your liver enzymes and different tests done on a routine basis. But that's not always the case on over the counter. So I was sort of glad when they blocked the statins from going over the counter. So when we look at the drugs, these statins, again, so many people are on them. And in fact, when they first came out, they were expensive because they were name brand. And what we would see is if you had a good insurance plan and you came in with cholesterol, we put you on a statin. If you did not have insurance or your insurance plan was very bad, we would put you on niacin. And simply it was a cost issue. These statins were expensive. They were name brand still. Niacin is an over-the-counter vitamin, which you could buy without a prescription. But even if you wrote a prescription, it'd start cheap. So that was what we saw when these drugs first came out, was really, actually the statins work better, I think, than niacin. But the issue becomes that we could still get a reduction in cholesterol, but if the patients couldn't afford it, that was it. Yeah, we'll talk about that niacin flush that can occur, which is a side effect that occurs sometimes with niacin. So when we talk about niacin, we're going to talk about that. But really, the 2 things with niacin, just to mention them real quick, is one, there's this that flushing effect that people have. And the only other concern was with niacin to begin with was that niacin could, there was reports that niacin could elevate your liver enzymes. But generally what happened, the liver enzymes went up to the upper limit level, the upper limit, upper normal, UNL, the upper normal limit. They really didn't, or if they did go above the upper limit, it was just barely over it for most cases. So one of the things we did, let's go back to the statins. So one of the things that we do know is that statins, as much as people use them, we still need to check liver function, especially if we start increasing the dosages. Typically on the low or the second highest dose, we usually do okay. But when you start getting on up, you may start seeing some effect on the liver. And what we typically see is that the liver transaminase levels can be elevated. Sometimes they elevate, still stay within the range, and that's one we just sort of watch. But we see that that when you get about a 3-fold increase, there's about 1% of the population that's on statins that may have that liver enzyme. If you have somebody with already liver or some sort of liver problems already there, or maybe taking another drug that is an issue, then we definitely want to be careful with that, simply from a standpoint of just monitoring it. It's dose related. So like I said, typically It doesn't occur at the low doses, but when we start increasing doses, that's an issue. One of the things we have to watch about, there are some drug interactions we'll touch on in just a moment that can create a problem. But if we start seeing the liver transaminases start being elevated, then we typically are going to stop the drug and see if let the liver sort of recover. Typically within 2 to 3 months at most, the transaminase levels go back to normal. So if we still have an issue with cholesterol, we're going to still try to do diet. We may try using another drug that doesn't have systemic effects, such as the bile acid sequestrant. Obviously, the bile acid sequestrants and everything are not going to be, we're not going to get the same level of result with those, and they may have other effects. The GI effects and the palatability may be a concern. But sometimes what they'll do is they will stop the, they may sometimes lower the dose of the statin and see if the liver enzymes drop down, or they may take them off the statins and then restart them at a lower dose a little bit later on. Probably the biggest thing that with the statins that we worry about is actually this myopathy, okay, and the greater effect of where we have actually muscle damage. So what we find is that when you inhibit cholesterol synthesis, one of the things that's happening is that will also inhibit your muscle cells need cholesterol for cell membranes. And so one of the things that we find is that people can, elderly people in particular, may start developing muscle pain or weakness, okay? Occurs in about 1 in 1,000 patients has been one estimate. And the way we check this is if you have a patient came in and had muscle pain or weakness, one of the concerns would be, and they were on a statin, one of the concerns would be, is the statin creating this myopathy, okay? If the clinician that's prescribing this, you would want to refer them back to whoever's prescribing it, and or maybe pick up the phone and call the individual and say, you know, this is my patient here. You're prescribing, you know, this person is having this this muscle pain or weakness that they're reporting. What we typically will do is we will measure, they call it either creatinine kinase, so CK, or CPK, which is creatinine phosphokinase. Those terms are used interchangeably. So what we see is that if we measure that and we are seeing an elevation, typically 5 to 10 times above the normal limit, that means that creatinine kinase, or that creatinine phosphokinase, is an intracellular muscle enzyme, which means if it goes up in the blood, that means that muscle is being broken down. So the concern is we would want to stop the statin immediately and let the muscle recur, because here's what can happen. The myopathy, typically where they complain of pain, and this isn't unique, but it's a very common complaint, is they complain that their lower back and their calf muscles tend to be showing weakness or muscle pain. And so especially if we get that. Now, you've got an elderly person that goes out and works in their yard, or maybe goes walking. A lot of times they may just simply think, okay, I just overdid it this weekend. But my uncle was, he was a pastor, and he really didn't do a lot of exercise, but he was on the go all the time. And he called me and said, you know, he was taking Rivastatin, and called me and said, you know, my back and my calves seem to be hurting. Could it be some of these drugs that I'm taking? So when I saw he was taking Rivastatin, and I saw also that they had just done a dosage increase, I told him to go back to his doctor and tell his doctor to check his CK levels. And my uncle did do that, and his CK levels had been elevated, so they took him off the Rivastatin and for a while, and then started him back at a lower dose a little bit later on. Now, his doctor would never admit, I think his doctor was afraid of getting sued. His doctor would never admit that the Rivastatin had caused it. But the point becomes is it occurred right after a dose increase. When he reduced the dosage, it didn't reoccur, and there was no other explanation for it. So we're pretty sure that's what caused it. But his doctor, my uncle, asked him numerous times, and I told him, I said, well, you're a preacher. You should tell him you should not lie to your preacher. But we do see this, and we see it with some of these statins. And our concern is that when the creatine kinase levels start going up, means the muscle cells are breaking down. And so if we catch it early, that's fine. But when we get extensive breakdown and we start getting levels up greater than 10 times the upper limit of normal, we get a breakdown of rhabdomyolysis, a breakdown of muscle tissue. And when those muscle cells break down, there's the pain and weakness. But the bigger concern we have is that basically, as these muscle cells break down, they start releasing myoglobin. Myoglobin is a protein inside the muscle cell. So the myoglobin gets released, it gets put in the blood, and the blood by the bloodstream, it's carried to the kidneys to be filtered out. And what happens is myoglobin, when it gets into the kidneys, as one nephrologist described it, is basically, it's like sludge. So this myoglobin, which is the muscle protein that's released, basically will just clog up the kidneys, and you can go into acute renal failure. And that's our concern, is the rhabdomyolysis, it creates muscle pain and the breakdown, but from an overall health situation, our concern is rhabdomyolysis can lead to kidney failure, okay? And people can die due to kidney failure. Now, some of you may have heard about rhabdomyolysis with other things. For example, there was a concern with when the CrossFit exercise boom was really going on. One of the things that we started seeing was an increase in rhabdomyolysis, where people were exercising very excessively. And so there's a lot of other things that can cause rhabdomyolysis, but the statins can do it too. Typically, catching it early enough, it's usually reversible. When we get to the renal failure, we got to catch it fairly early, or it could be irreversible. So, Angela, you had a friend that got, there was actually some public information, public announcements out about concerns for people pushing the CrossFit. Not to say that other exercise programs, we have seen people that have been lifting weights that can develop it. In fact, when Cerevastatin was pulled off the market, one of the things that came up was, did you see any cases of rhabdomyolysis in clinical trials? And they said no. It turns out there was one guy that did develop it, and he was a weightlifter, so they basically blew off the fact that it was the drug causing it. They said it was due to his weightlifting. The other thing that the company did, which was sort of interesting, was their protocol in the clinical was that if someone's CPK levels reached a certain level, I think it was 5 times the upper limit of normal, they were pulled out of the trial. So when they were asked, did you have any cases of rhabdomyolysis, their answer was no. They explained that their explanation was the guy that was lifting weights to weightlifting, not their drug. How they determined that, we don't know. But the other thing that they said was that basically we had no rhabdomyolysis cases. Well, the reason they didn't have any rhabdo cases is basically when somebody's CPK levels started going up, they pulled them out of the trial. So they really didn't provide information that we had all of these people that were, that it was sort of buried, but they really, didn't emphasize to the FDA that we had a number of people that elevated myopathy. In fact, one of the memos that came out from internal memos says, of course, you don't have any rhabdo cases. You pull them out before they develop it. So there was signals all through that, but that's eventually why the Cerevastatin got pulled off the market. But Angela, the thing is that we see a lot of people that do CrossFit. and do various other exercise programs. And and they do fine. But we do see some of these individuals that just sort of get in it and just push themselves way too much. I know when I'm doing martial arts, when we're doing Krav Maga, when we get new people in, we always make sure that we talk to them specifically with regard to you don't have to push yourself. And we've had a few of them get a little green around the gills, and we show them at the very beginning. We tell them, if you start pushing and it starts becoming uncomfortable, then just stop. There's no shame in that. Just take a breather and rest up. We show them also. We've learned very quickly to show them where the door is in case some of them get nauseous. That makes it a nice, cleaner situation. But one of the things that we do see, especially this time of year, is a good example. People are fixing to go to the pool, the beach, and have less clothes on, so they suddenly want to get rid of several months of chowing down and everything else, and they just try to really push themselves. I mean, I have friends that do go to the gym 2 and 3 times a day. They do legs in the morning and upper body in the afternoon, and or in the evening. So I have friends that spend 2 to 4 hours in the gym per day, and these are serious people. And some of them we've talked to simply from a standpoint is they're not letting their body actually recover. Now, the other thing that we worry about here is that many statins basically go through metabolism by P3A4. And so one of the things that we have to be careful about is that when they're taking other drugs, it is very possible that the dose of statin that they're doing is fine. But one of the problems that we run into is that those individuals basically then take another drug, which elevates the statin level by slowing down the metabolism. And by doing that, that basically kicks up the statin levels, and that can cause the rhabdo. Because the myopathy in rhabdo is dose dependent, okay? And so we also see that other drugs, sometimes we use combination, we'll use a couple of drugs to try to lower cholesterol in some individuals. But if they're taking fibrates or niacin, if they're taking those, sometimes people taking large doses of niacin in addition to this, they're going to be at an increased risk, because fibrates and niacin can also, they're inhibiting cholesterol synthesis, but not at the potency that you normally see with individuals that are taking that. Other things that put you at specific risk for myopathy, people that have liver dysfunction, because the statins are not going to be metabolized as quickly. Renal insufficiency, because the kidneys are not working up well, so that means any myoglobin can cause more damage, and because the renal insufficiency can result in a buildup of statins. Low thyroid, hypothyroidism, so you're not metabolizing. Older people, advanced age, infections, these are all things that can actually increase your risk for rhabdomyolysis or myopathy. So that sort of talks about the statins. So let's move right into niacin. So niacin, we know, first of all, the niacin that we're using is, when people take niacin for a vitamin supplement, that's a much lower dose. When we're using it for lowering cholesterol, we're talking about like 2.2 to 2.5 to 3 grams, okay? So niacin, like if you go to the pharmacy and it's out front and you go up to niacin, some of these pharmacies will have the dose for vitamin, so maybe 50 milligrams or 100 milligrams. If you're using it to lower cholesterol, we're using like 2.7 grams. So if you've got the 100 milligram capsule or tablet, that means to get 2.7 grams, you're going to have to take 27 tablets. Okay. So what and most pharmacies are carrying it. We have higher dosages now. And what we used to tell people if they were going to get niacin, if the pharmacy didn't have it, tell the pharmacy to order the higher dosage or the higher concentration. So there's 400, and I think there may have been some 800 milligrams. So they didn't have to take as many there. So what we see is that we're not exactly sure how niacin actually decreases LDL production, but it does. And don't see quite the same with niacin, whereas with the statins, we can get up to like 40%, 20 to 40% is pretty average. With niacin, we're looking at about 10 to 25%. But one thing that niacin does do better than probably any of the other drugs is it will increase HDL. And that's an issue that we are running into, is that sometimes we use the niacin to increase the HDL. We have recognized that people that have normal cholesterol and low HDL may be at a risk. So HDL can be an independent factor. Okay. So the big thing with niacin, although it does decrease LDL production, not as good as the statins, probably not quite as good as the bile acid sequestrants, but the big thing, it does increase the HDL. And we've already talked about the biggest concerns. One is the rash or facial flushing. So that is probably related to prostaglandin. So if someone takes some aspirin, like about 30 minutes before they take the niacin, then that usually takes it. A lot of people, they get the flush, but some people get some of the itching. And that seems to be due to a release of prostaglandins. So if you take an aspirin about 30 minutes before, it usually blocks it. The other thing is there's always been concerns about niacin, because we have seen where that people's liver enzymes elevate, but we have not seen really any large number of cases of enzymes, severe hepatic injury with the doses that are being used. Okay, so we're at a good place to take a break. And I saw from the chat board that there seems to be the sound or the thing seems to be going in and out. So I'm going to do a couple of things when we take this break. So one of the things that we will do is I'm going to sign out and come back in on Zoom and see if I can get a better connection and see if that helps when we get back from break. And then we'll pick back up starting on the fibric acid derivatives. Does anybody have any question before we stop for break? All right. So why don't we do this? We'll take our break, our first morning break. Let's come back at 15 after the hour, and then I will pick up again. So a couple of you saying the sound has gotten better. So it may have just been a glitch, but I'm going to pull back in and see if I can get a little better connection just to make sure. So, but anyway, I will see you guys at quarter after the hour, and we'll pick back up on some other cholesterol drugs. Okay, guys, we're going to go ahead and get started back. Let's go to full screen here and see if that'll. There we go. All right. So let's pick back up. So we covered the statins, the bile acid sequestrants. We've covered the niacin. So another group of drugs that we find have been used, and again, these are not used quite as much as the statins. The statins probably are the premier drug that's always being used, and the other drugs are used to a much lesser extent. So these are fibric acid derivatives, and these drugs, these seem to have a greater effect on triglycerides. They can also increase the HDL. They will decrease the LDL, but we do have, you don't hear a lot of discussion about people that have hypertriglyceridemia. But some of these people, they can actually get these triglycerides and fat deposits like nodules in their skin, and they have elevated triglycerides. And so these are basically, they have been used to lower LDL, but they've been more effective at decreasing triglycerides. And we do see that they are not as effective as niacin for increasing the HDL, but they can. Some patients we may get about an equivalent time. But again, these tend to be more for lowering triglycerides. And their mechanism is actually where the mechanism falls down to these drugs is that they are called, they're PPAR, drugs. PPAR, what that is peroxisome proliferator activated receptors. And there's an alpha that results in there. But basically what they do is they activate the PPAR alpha receptor, and that decreases the VLDL, which is the very low density lipoprotein, and also the low density lipoprotein, the LDL, and increases the HDL. So what I want you to really think about with these, as far as if I were to ask you the mechanism, where did you go? Where it goes? Oh, I jumped ahead there. So with the fibric acid derivatives, we have one that we see used the most probably is gemfibrozil, and basically we see fenofibrate and fenofibric acid. Then I had missed that slide. So basically, if I were to ask you the mechanism of action, what I would want you to know is basically that they activate PPAR. Okay, so these are PPAR activator receptors. Okay, and that's how they reduce the cholesterol and LDL. Now, with fibric acid derivatives, there are some pretty common side effects, and these side effects are sometimes unpleasant. And one of the reasons that they may not be used as, again, they're not as effective in general as the statins, and these side effects are not a real big problem. I mean, basically, they do tend to produce a lot of indigestion. They tend to produce a lot of the maybe some abdominal pain, bloating, gas, some diarrhea. Some of them produce a rash and muscle pain and fatigue. So these are typically not life-threatening, but these are very uncomfortable. And so that's a big concern there. What we find is that if you're using a statin and going to add this, they typically use fenofibrate because it basically reduces the side effects of some of the statins. But the biggest concern with these fibric acid derivatives really falls into they can increase the cholesterol concentration in the bile. And when you increase the concentration of cholesterol in the bile, what that does is, think of your old chemistry days, or maybe when you did this with your kids, or your mom and dad did this where you do these supersaturated solutions. For example, you take and heat up water and basically dissolve as much sugar as you can, or salt. So you get this really supersaturated solution. Then you drop a string down in it. Sort of the same principle here. So what these do is they actually increase the amount of cholesterol that's actually in the bile. And what that does is So what that does is basically um, cause the cholesterol to get real concentrated in the bile, and that produces gallstones. And that cholelithiasis and cholecystitis is actually the inflammation that occurs due to the presence of the gallstones. And so one of the things that we have to be careful about is with the fibric acid derivatives is that they can produce that. We do not use this in patients that have existing gallbladder disease. The main reason is it's going to make it very worse. We don't want to use it in patients with liver dysfunction or has severe renal dysfunction because, again, increasing these drugs can increase the amount of cholesterol and can create some major problems. By the way, I reconnected and everything. Is the sound? I'm assuming the sound is back where we seem to be doing pretty good here. Yeah, good. All right. So we're just, I mean, we've been very successful with Zoom lately, other than, you know, I think we've worked out some of the things there. But as far as the presentation issues, we've had a lot less than what we used to have with Moodle. And but if you guys do see where the sound is coming and going, let me know. Sometimes what can happen, and it's easy for me to do it versus you guys trying to do it. But one of the things that sometimes will happen is I can switch from one bandwidth to another. Sometimes that helps out, like this I think did recently. Okay, so we've had these drugs, and one of the groups of drugs that's been coming out, or new class of drugs, shouldn't say new, but another class of drugs that sort of emerged has been the drugs that they inhibit the absorption of cholesterol. Okay, so the theory here is that that with most of the cholesterol coming through our diet, then the idea here is that if we can, number one is we're going to tell people to basically watch how much fat intake they take in, and so by doing that, one of the things that we see is basically we know that by reducing the amount of cholesterol and fat absorbed, that will reduce our cholesterol and so forth. So here, what we're looking at is ezetimibe. Basically, and this is actually available with in combination with a statin. So it's available as the drug by itself, or actually as a combination product. So the idea with putting it with a statin is that basically the statin decreases cholesterol synthesis, and this would decrease the amount of cholesterol absorbed. So what this basically does, this drug will block the absorption of cholesterol coming through the biliary system, as well as what you're taking in as a diet. And so what you actually have is that in your in the GI tract, you've got these brush border cells on the enterocytes, which are some cells there. And the brush border also is able to do it. There's a transporter there, so you've got a lot of surface area, and it helps transport cholesterol in here. So what the ezetimibe does is basically interferes with that particular transporter, and the transporter is it's called the NPC1L1, and so that is its basic mechanism. Pretty much, I'm not going to ask you what the transporter's name is, but I would ask you on if I ask you for a mechanism of action, it's basically going to be blocking the absorption of cholesterol, and by interfering with the transporter. Okay, so pretty much what it does is it inhibits about half of the cholesterol that comes in through the intestine. Okay, again, like we've talked about before, that when you drop the amount of cholesterol coming in, then the hepatic cells need cholesterol, need to pull it out of the blood to be able to make a bunch of things that are cholesterol dependent. So one of the things that's going to happen is that when the cholesterol is not being absorbed, and in fact, if we drop, think about this, if you use this drug, you get about 50% of the cholesterol, intestinal cholesterol absorption. And so if you can get a good reduction in cholesterol intake, you can have a pretty good drop there. So when the cholesterol in the bloodstream goes down and the LDLs go down, then what happens is, just like what we've talked about before, the body upregulates these LDL receptors and to try to pick up more cholesterol. And that's what occurs. Now, the other thing that can happen is when we use this drug by itself, and people still use it by itself. One thing that happened is when the cholesterol levels go down, remember HMG co-reductase? Well, you know, that's the enzyme the statins block. That's the rate limiting enzyme. Well, sometimes what happens by using ezetimibe by itself, what happens, cholesterol level drops and the body starts synthesizing cholesterol to make up for the decreased absorption. So that was the rationale for actually, that was the rationale specifically for adding a statin, is to block that compensatory increase in cholesterol synthesis. One of the things that'll happen is ezetimibe basically gets converted to an active metabolite. It can undergo intrahepatic recirculation, so it stays around a little bit long. But typically what we see with this drug is not as good as the statins, but we see about an 18, 20% reduction in LDL. One of the big things is we don't get the systemic absorption. We get a little bit, but not a whole lot, and therefore the side effects are minimal. The biggest thing that we find is that if there's a liver issue, we want to avoid this drug. So if for some reason we have liver function tests are elevated, we just don't want to use this drug. But again, generally, this is pretty well tolerated. And one of the things with the liver is that you could, if there's liver dysfunction, you may not get the metabolism of the drug. All right. So what we've talked about up to this point is basically this morning has been primarily the effects of the drugs that are going to interfere with cholesterol and plaques. Okay, so we primarily talked about these drugs that we use. Many people call them anti-cholesterol drugs. Okay, so we've included, you know, the bile acid sequestrants. A big concern about that one, remember, is that it can interfere with absorption of other drugs. So that's a big concern with that one, but it has very little systemic effects. The statins are probably the number one drug that everybody uses. Niacin specifically is good for elevating the HDL. I will tell you that we had one of my faculty members. He was an older guy, late 60s, and which seems young now that I'm at you know, my 63, 64-year-old range here. But my secretary came to me and she said she was real concerned about him because he would be in his office, and when he would come out, he would just be beet red. And she said, you know, I'm afraid he's going to have a heart attack. Well, you know, I went to check on him and so forth. What I found was he was taking niacin, and he would take it usually early in the morning, or if he forgot, he took it a little bit later around lunchtime. And a lot of times he would be sitting with his door closed. And so when he would get, you know, walk out of the door, out of his office, for whatever reason, he would just be beet red. And my secretary was afraid he was having a heart attack. That same faculty member, when we had, he would take naps. I'm going on a little tangent here, but he would take naps. And one day he took a nap while he was reading an article, a Xerox copy of the article. He was sort of bald, and apparently his head was laying on the article. And when he got up to, a student went to see him, and I heard the students laughing, and I went to check to see what was going on. And this particular faculty member basically had the, where he had slept with his head on his desk on that article, it had basically left, the ink had not been dry apparently, so across his forehead was the title of the article. So the students were, you know, nobody really wanted to tell him that, you know, that you have the title of an article across the forehead, which we knew he got from sleeping. But again, with the niacin, the biggest thing is we worry a little bit about the liver enzymes. We haven't had any real issues there. And but we do see the flushing. From a standpoint of the statins, they are the, you know, we got to worry about rhabdomyolysis. We got to worry about liver function. They are effective. And then we talked about the fibric acid derivatives and the cholesterol absorption inhibitors. Okay. So now we have a person. Let's move to the next disease state. And the next disease state is angina. So it sort of flows right into, you know, people, a lot of times we see cholesterol building up. we are worried about them developing a heart attack. And so as a result of that, one of the big things that we're looking at is that they may start developing angina, which is going to be what happens is that refers to the pain that occurs when the heart can't get enough oxygen. Typically, that angina is going to be a consequence of a blocked vessel, which is dealing with a plaque or a ruptured plaque that has built up. So the cholesterol agents, what we're trying to do is we're trying to decrease the development of those plaques. And then these drugs we're going to talk about in just a moment are the ones with people that have developed angina, so have actually had heart attacks or having chest pain. Now, when we're treating angina, basically the pain is occurring because the heart is not getting enough oxygen. So we've got ischemia that's occurring. The ischemia, the heart cannot function as an anaerobic organ. It needs oxygen. So when it can't get enough oxygen, what it's going to do is it lets the person know by creating pain, which theoretically the person stops doing whatever they're doing and the oxygen demand goes down. So when we treat angina, and what we're hoping to do is we're either treating angina prior to a heart attack or we're treating angina after somebody's had a heart attack and may still have some symptoms. So there's a number of drugs that we can use, and you probably are familiar with several of them. But typically the way we're treating people that are developing severe angina or have an infarction is going to be primarily we're using stents. So that's the new thing is in the past we used coronary artery bypass. So what we literally did was we took a blood vessel from the person's leg or from their chest. There's a vessel called the internal mammary artery, which is right at the level of the heart. And we just simply did a bypass over the blockage. So we would sew it so simply, you just take that piece of blood vessel, the saphenous vein, most commonly used, and you just rerouted around the blockage. The problem with that, one is the surgery was extensive. You're cracking the person's chest open. So it's major surgery. Second thing is many people that had bypass, because of the change in flow, a lot of times they redeveloped angina within about 5 years. Then we went to what is called they affectionately refer to it the Roto-Rooter, which is the angioplasty. And so with the angioplasty, what they're doing is they're passing a catheter into the blocked blood vessel, and then they inflate a balloon, and the balloon basically pushes the plaque up against the wall, so it opens up a channel through the plaque. But now what we're seeing is, and a lot of times what would happen is they would take people in for angioplasty, and if the angioplasty didn't look like it was going to work, they would just go directly to bypass. Now probably the number one surgical correction is stents. And what stents are is basically the stents are like a little coil of wire, and we can insert those through. We don't have to open the chest. We basically thread with angioplasty and stents, we basically thread a catheter. Used to, we went through the femoral artery or the groin area. Now they're doing the stents. They're going in through the wrist. And so they basically go into where the blockage is and insert the stent, which is sort of a little coil of wire that sort of keeps the blood vessel open. And some of these stents are impregnated with some drugs, which tend to inhibit platelet aggregation. So typically what we do now is we will treat the angina with drugs, but we treat the main problem by putting a stent in. All right, so let's look at the anti-anginal agents. These are primarily designed to alleviate the pain. They're not curing anything. They're not going to dissolve the clot. They're not going to do any of that. What they're basically going to do is they're going to alleviate the pain. And the number one class of drugs that we see that is used for that is going to be the nitrates, okay? And there's several products out there. We're going to use two here as our prototype, nitroglycerin, and the other one is isosorbidide dinitrate. But we have a number of formulations. For example, erythritol tetranitrate, pentaerythritol tetranitrate. these are all acting the same way. And this is what we use typically for the quick relief of the angina pain. So typically after a heart attack, individuals are given nitroglycerin, some form of nitroglycerin. They're going to be short-term acting. The idea is to open up the blood vessel and maintain blood flow. They're not long-acting typically, but we have a number of preps that may have a little bit longer acting. Another thing we may use for anti-anginal agents is beta blockers. So one of the things that can occur with the beta blocker is by slowing the heart rate and decreasing contractile force, then basically what we're going to do is the net effect is going to be decrease the work of the heart, so oxygen demand goes down. The calcium channel antagonist, they're going to be vasodilating, so we use those. And then there's another drug called dipyridamole, which is not real effective, but it is used as a sort of a vasodilator. So again, the main thing here is that we've got a blood vessel in the heart that are one or more blood vessels that are not allowing enough perfusion. So these drugs are going to either decrease the work of the heart or cause vasodilation, or a combination of the two. So the nitrates, and this is all of them, nitroglycerin, all the different forms. So a lot of people think what the nitroglycerin does is it vasodilates the coronary artery. And it does do that, but that's not its main mechanism of action. Nitrates can produce some pretty prominent venous vasodilation. And it's actually the vasodilation in the periphery, not in the heart itself, that makes it effective. So what this does is it causes your veins carrying blood back to the heart to vasodilate. So that's going to decrease the return to the heart. Venous return is the amount of blood, is the blood being returned to the heart so it can be pumped again. So its most important mechanism is basically it's going to vasodilate that blood coming to the heart. And by doing that, it means when you're bringing a lot of blood back to the heart has to work hard to pump that out. But what the nitrates do is the nitrates vasodilate those veins, which decreases the amount of blood going to the heart. And when the heart doesn't have to work as hard, then the oxygen demand goes down. That's its main mechanism. It basically causes vasodilation, which reduces the amount of blood being carried to the heart, which means the heart doesn't have to work as hard. So when the heart's work goes down, what's going to happen is that there's less oxygen demand. So that's the most important mechanism. It will also, that's the most important. This is the most important mechanism here, okay? But what it also does, and this is, these are sort of secondary things that contribute, is it will dilate the large blood vessels, the large coronary arteries in the heart. And so that does help. By dilating the large coronary arteries, that means that they're able to deliver more oxygen to the heart tissue itself. So we're reducing, the main effect is we're reducing the work of the heart. And then secondarily, what we're doing is we are going to dilate the coronary arteries, which allows better perfusion. And the other thing it's going to do is by dropping or dilating the blood vessels, it means the blood pressure can drop, which means the heart doesn't have to work as hard. So nitrates, a lot of people used to think that, oh, they just dilate the blood vessels in the heart, which opens it up and lets blood get through where the blockage is. And that they do that, but it is not a, that doesn't see, it's not as prominent of an effect. It's more of causing vasodilation in your periphery, which means that it slows down there's less blood being returned to the heart to be pumped by the heart. So that's it. Now, some people also will have spasms. So the coronary artery spasms down, and so the nitrates can alleviate that. Now, the nitrates, the biggest problem with nitrates are that they're vasodilators. And if you think about what we talked about yesterday with hydralazine and minoxidil, those vasodilators can produce some headaches. And some common things that we see I mean, most of the side effects of nitrates are due to excessive vasodilation. Okay. So one thing is headaches. When your cerebral blood vessels dilate, one of the things that happens is they enlarge, which pushes against the nerves. So many people complain of nitrate-induced headaches. We see orthostatic hypotension because you've got vasodilation. It makes it more difficult to get up. One of the big concerns we have sometimes is tachycardia. If the blood pressure drops, if we get too much vasodilation with the nitrate, then one of the things that can happen is that basically it's a situation where that their heart rate starts speeding up, and when the heart starts speeding up, basically the heart's work increases. So sometimes we have to be careful about the tachycardia, and some people will have a flushing effect. Their blood vessels will basically your face will get sort of red. So typically the side effects are due to excessive vasodilation. The tachycardia occurs because of the blood pressure dropping and the reflexes kick in. Okay. There is one interaction which is almost notoriously famous, and that is with Viagra. Nitrates and Viagra you do not use together. The reason for that is Viagra is actually a vasodilator also. And so the idea with how Viagra works is basically where that an individual, when they take the Viagra, it causes vasodilation in the penis and in other blood vessels also, but that's how they work to perform an erection. So if someone is taking nitrates and has Viagra, what can happen is the combination of the two vasodilators can actually cause an excessive drop in blood pressure, which can be potentially life-threatening. I will tell you that we've had a couple of things that's occurred with the nitrates. There was actually a case study that was written up where that there was a guy, and nitrates, typically we can use them, put them underneath our tongue, or we have some gels and so forth. One thing is a lot of people says to make sure the nitrates work, they should cause a stinging feeling if you put them under your tongue. That's not always the case. So just because the nitrate doesn't sting under your tongue doesn't mean it's not effective. But we do have concerns because people will get nitrates and they don't use them because they don't have to use them. And so some of those nitrates, some of those drugs can expire. Or the other thing is people keeping them in their bathroom where it's moist and damp, keep them in their car. So we do recommend that individuals get a new prescription, at least annually, so they know that their nitrate is working. Most of those individuals, if they've had a heart attack, the doctor will basically say to you, take a nitrate. If it doesn't, and then if it doesn't relieve the pain, take another one, and maybe do it 3 times. And if you haven't had the pain relieved, then head to the hospital. What I was going to tell you is that with the nitrates, that we did, there was a case that was written up where this guy, what had happened was his wife was developing severe headaches. And these particularly were occurring after they had sex. And it turned out that he was on nitrate, on a cream, and he discovered that if he used the cream basically and applied it, that could produce an erection. And she did not know that. And so what was happening is, and they did a complete neurological workup on this woman, trying to figure out why she was having these headaches. Well, it turns out she was actually having nitrate headaches because what he was doing is actually using the nitroglycerin, applying it to his penis to basically to get an erection, which then when they had sex, basically she was absorbing it. And so she was actually getting nitrate headaches. And I was telling a buddy of mine who worked at the hospital, he was a nurse, and he started laughing. I said, "Why are you laughing?" And he goes, "We just had a patient that came in that had all of the nitroglycerin patches were all put on his lower abdomen. So we figured that he was probably using that to increase his potency, if you will." Speaking of which, on nitroglycerin patches, which we do give people that have some prolonged angina, one of the things that we need to be it is that they can't cut these patches. The patches, we find a lot of times people do things like we've seen where that no one told them to take off the patch. So, they pulled off their shirt and they have several patches stuck there. Or they've called in and say, where do I put the patch? I've run out of room. You can't cut the patches. We've had people, women in particular, will try to trim it, maybe so it doesn't show above their, the neckline of their dress or whatever. We've had guys that have had real hairy chests that they're saying it's not working, and when we look, the patch is not even in contact with the skin. So these patches can't be cut. They can't be, so we have to direct people specifically how to do these patches. One of the things that can occur with nitrates is that a person can develop nitrate tolerance. In other words, the drug seems to not work anymore. And that can develop even after about 24 hours. Sometimes it takes a little bit longer. Not every patient will have this nitrate tolerance. There's a lot of different things people have put forward to try to explain these, why they develop tolerance. People have suggested that the sulfhydryl groups get depleted, that there may be some neurohumoral effect, their plasma volume had expanded, or free radicals. So a number of theories have been postulated. One of them is the sulfhydryl depletion. And what the belief is that a sulfhydryl group basically has sulfur and hydrogen in it. And that sulfhydryl groups in the cells, in the tissue cells, are necessary to transfer nitrate, or to transform nitrate to nitric oxide. Nitric oxide is basically the vasodilator component. So one of the things, the reason that they've suggested this is that some people that develop nitrate tolerance is that we can use a drug called acetylcysteine. And what acetylcysteine is it actually will donate sulfhydryl groups. So if you add acetylcysteine in, basically somebody that's developed tolerance then is now more responsive. But there are some arguments about whether that theory, we haven't really explained it. Some people say that it's due to the production of free radicals, which destroy the nitric oxide. Acetylcysteine can act as a free radical scavenger, so that may be another work. Some people said vitamin E, which is also a free radical scavenger, can reverse tolerance. But what you really just need to know is that nitrate tolerance can occur. Individuals may not respond to the nitrate. And so we do a number of things. As one, we've used acetylcysteine. People have used diuretics. People have used angiotensin converting enzyme inhibitors to reverse the nitrate tolerance or prevent it. Different mechanisms have been proposed. But typically what they do is we try to keep the nitrate exposure very low during a 24-hour period, or during each 24-hour period. And by keeping it low, we don't seem to develop the nitrate tolerance. But if it does develop, then it can be reversed, but it's just recognizing that it could occur. And what you would see is that a person that's taking the nitrates just doesn't seem to be responding. Another thing that we try to do is, instead of somebody staying on nitrates all the time, is by giving it to them intermittently. And that works in some patients, but sometimes patients will have what is called a rebound ischemia. What will happen is, when they're in the nitrate-free period, is the ischemia seems to be worse, and they have more angina attacks. And so the other thing is, when they took them off, when they stopped taking the nitrate, when you went to that nitrate-free area, is sometimes people would have difficulty with exercise tolerance. Their heart, they developed angina too much. They referred to this as the 0 hour effect, is basically when you got to zero effects, that's when it occurred. But it's just recognized that nitrates, that people can develop it, and we've tried to overcome that. We do have some long-acting nitrates given once a day. Those tend to have less adverse effects, but you may also have more tolerance. But there's just a lot of questions. It's a well-recognized phenomenon, but there's a lot of questions with regard to the exact mechanism. And one of the reasons there was so much interest in it is drug companies were looking at trying to produce a very prominent or a good or a more effective nitrate, because we do see a need for that. Okay. Okay, so let's cover the next class of drugs. So that's the nitrate of the angina type drugs. The beta blockers we touched about. We've talked about the calcium channel blockers. Let's talk about the drugs that are used for heart failure. Okay, and the drugs that actually stimulate contractile force, we refer to those as inotropic drugs. So if they increase it, it's a positive inotropic effect. If they decrease it, it's a negative inotropic effect. So the drugs that we're using in heart failure we refer to these as inotropic and some people refer to it as inotropic. But these inotropic drugs, we want to stimulate the heart to pump harder. So one of the problems we have with these drugs is many of the drugs that we have that are stimulants are short acting. We don't have really a dosage form. One drug which we did see used quite a bit was digoxin, and you've got a picture of foxglove here. And digoxin was derived from foxglove. We have a derivative of digoxin called digitoxin, which is a longer acting drug. The digoxin, and I'll refer to them as either digoxin in general or cardiac glycosides. These drugs were used initially for heart failure because they do stimulate the heart to pump harder. Okay, and the way they do it is they actually bind to the receptor that the cardiac glycosides, this is digoxin and digitoxin, they bind to the sodium potassium ATPase. Okay, so by binding to the sodium potassium ATPase, they inhibit it. And the sodium potassium ATPase, as the name implies, is going to be responsible for, after the cell is depolarized, it pumps potassium back in and pumps sodium out. Okay, so if we inhibit the sodium potassium ATPase, what is going to happen is that sodium accumulates in the cell. And one theory is that what happens is the sodium calcium ATPase then kicks in to pump out the sodium and brings more calcium in. And when you bring more calcium in, then you have a stronger contraction. So the net effect, and there's some people that argue with this mechanism, but they all agree that by inhibiting sodium potassium ATPase, the net effect is that you get an increase in intracellular calcium, which then results in a stronger contraction. Okay? Now, one of the things is that we do know that the therapeutic effect is due to the binding and inhibition of the ATPase by the cardiac glycoside, by digoxin. So that's what does the therapeutic. But we also know that the toxic effects are due to the same thing. So there's a dose dependency, and many of these drugs have a very narrow therapeutic index. So digoxin, the dose at which we get a positive effect is a therapeutic effect is very close to the dose we get the toxic effects. And think about all of the cells that use sodium potassium ATPase, so we can get a wide range of adverse effects that occur with these cardiac glycosides. We have to be very careful. Now, look at this next statement. Binding to the ATPase is inversely related to potassium levels. So let's go back to the other slide. All right, so here we have the binding here, right here, okay? So the inverse relationship, when there is a lot of potassium, then there is less digoxin binding. So it's an inverse relationship. When there is low potassium, there is more digoxin binding. And if there's more digoxin binding, then basically we are dealing with greater inhibition, all right? So that creates a problem, okay? Because with congestive heart failure, what other drug class do we use? We've already talked about it, but what other drug do we use for, types of drugs do we use for congestive heart failure? Does anybody remember? Diuretics. What do diuretics do to potassium levels in general? They decrease. And a lot of times we're using furosemide or Lasix, those really powerful diuretics. So one of the things that sets us up for a problem is by using the diuretic to get rid of the fluid, we lose potassium. And when we lose potassium, that means more digoxin binds to the receptor. So one of the problems is that we can get drug toxicity. So that is a big concern, is we have to be careful. And in fact, the cardiac glycosides are responsible for a large number of drug toxicity cases. And many times when they come to the ER with suspected digoxin toxicity, if we pull the blood, we find that they're hypokalemic. So what's happened is their potassium levels have dropped, which allowed for, they haven't taken too much digoxin. It's just at the dose they've been taking that the potassium levels have dropped too much. We used to tell people, to basically eat more bananas and the potassium-rich foods and stuff, but most physicians just found out it's easier to control your potassium levels by giving you a potassium supplement. We don't know how much potassium you're going to get in each banana that you eat, because bananas differ in size. They're botanical products, so the amount of potassium can vary. So we used to see people just say, well, eat a lot of bananas or this, that, and the other. But now physicians will just control the potassium by doing a supplement there. So that's one of the problems with these cardiac glycosides, is they can produce some really big issues. When we look at the toxicity, the elderly and infants, like all drugs, are usually more susceptible. But in particular, the elderly patients are more likely to be on this drug. And because their kidney function has decreased, we may get a buildup of the digoxin. We may have problems with regulating potassium. So that's an issue. And as we just talked about, the presence of diuretics will predispose the patient by decreasing potassium. But also we found that if magnesium levels drop, these individuals actually did some of this work, that people that are hypomagnesic, so that have low magnesium levels, they can be susceptible to digoxin toxicity. We also have to be careful because some drugs that they're taking can actually displace the cardiac glycoside from a plasma protein. Some of the calcium antagonists, ibuprofen, quinidine, just a few examples of that. And here's what there is no first sign of toxicity. So we don't have a predictable first sign. Used to, they would load people with the digoxin, and then they would somebody's coming in with heart failure, they'd give them a bolus dose, and actually what they would do is they would give them a dose until the person started getting nauseous, and then they would stop giving the dose, and then they would put them on an oral maintenance dose. But what they discovered was that nausea and vomiting was not the first sign of toxicity. In some patients, we saw the first sign of toxicity could be a severe arrhythmia. In other patients, it may be hallucinations. In fact, we can get some pretty strong psychological effects. Disorientation, confusion, depression, hallucination, convulsions can all occur due to toxicity. One thing that we call pathonomic, which means that if your patient comes in describing yellow-green halos, that is pretty significant or pretty specific for digoxin. And we can get gastric distress. It can produce any known arrhythmia. And what we do see is that the one big contraindication is you never, ever, ever give cardiac glycosides to someone with a ventricular arrhythmia. We actually use it to treat supraventricular arrhythmias, which are atrial arrhythmias. But you never, ever, ever, it says an absolute contraindication, give digoxin to someone with a ventricular arrhythmia, okay? So a lot of signs of toxicity. Typically what's going to happen if we suspect it's digoxin toxicity, we tell them to stop taking the drug. We check their potassium levels. And by checking their potassium levels, if their potassium is altered, we adjust that and then can restart them. If their digoxin levels are elevated, we will have some people maybe have some renal problems or whatever, that they may get too much digoxin. And so that's the way we pretty much handle that. So basically, stop taking the drug. check the potassium levels. We do have an interesting antidote that they've developed. It's called Digibind. So if someone has too much digoxin in their system, we inject this, and what it does is it actually binds to the digoxin drug, the molecule, and prevents it from interacting with sodium potassium ATPase. And this is usually if someone is overdosed on dig, but most of the time, what we see is that people that develop dig toxicity, it has been primarily due to low potassium levels. All right, good place for us to take our last break for this morning. So let's come back at about in about 9 minutes. So 10 after the hour, we're going to talk about the first group of antiarrhythmic drugs. And then we're going to, I've got a couple of videos for you guys when we break for lunch. And Marissa will do the 4 questions for lunch at about, when we break for lunch, we'll give them the 4 for the morning questions. So we'll do just like we did yesterday. So I'll see you guys at 10 after the hour, and we'll pick up on the antiarrhythmic drugs. Okay, guys, so we're going to go a little bit further and talk about the antiarrhythmic drugs. And we're not going to get through all of them before we break for lunch, but I want to start with them. So the antiarrhythmic drugs, let me go back for a minute. So I talked about digoxin for the inotropic drugs. The other inotropic drugs are drugs that you will probably not see unless you're working in a hospital. They're used temporarily. We use like dopamine, we use isoproterenol, we use epinephrine. Those drugs are only given on a short-term basis because of basically they're not effective orally, and they have to be given. Usually people are in severe heart failure when we bring them in and are putting them on those type of drugs. So we did talk about isoproterenol, we talked about the catecholamines, but I didn't talk about dopamine or dobutamine. And we did talk about epinephrine, but those are drugs that are used primarily to treat heart failure. We do use drugs like ACE inhibitors and some others that are used to help the heart work, but as far as purely producing inotropic, stimulating the heart directly is going to be the digoxin. And I do have a video for you guys to look at when we break for lunch, which specifically is going to talks about sodium potassium ATPase and the digoxin, how it binds. I've got a video on the statins and how they work, and then I've got a video that deals with some of these antiarrhythmic drugs. I think it's a relatively short video. I think it's just a few, maybe 6-7 minutes, maybe, if I remember correctly. So first of all, these antiarrhythmic drugs, one of the things we have to look at is when we have people that have arrhythmias, first thing we have to look for is, is the arrhythmia causing some issues? Okay. So one of the things it's going to be is, like, for example, most of us will throw a PVC every now and then. It's not going to affect us. Some of us, we may have a weird configuration of our EKG, which would be an arrhythmia. But in order to treat an arrhythmia, the first thing that we're going to look for is we need to know, it's a benefit risk issue. We need to know is the arrhythmia producing an alteration in the circulatory system? Okay. If it's not, then we have to take a consideration on whether we should treat it, because many of these antiarrhythmic drugs, although they are antiarrhythmic, many of these drugs may be pro-arrhythmic. So they may stop one arrhythmia and produce another one. And so sometimes the arrhythmia that they produce may be worse than the arrhythmia we started off with. In general, most of these antiarrhythmic drugs we're going to see fall into the category of they are generally cardiodepressants. And so that is going to be one of the things, is that they tend to decrease or suppress the overall contractility of the heart. We have very few drugs that we can use orally and on a chronic basis to actually increase heart rate. Typically, if their heart's beating too slow, we're going to have to put a pacemaker in. But we just don't have those. So most of these drugs are used to where we have arrhythmias that are either aberrant, so an aberrant pathway, or these arrhythmias basically are speeding up the heart too much. Okay. Now, the major mechanisms of actions, and there's different classifications of these. For example, these sometimes are called the Vaughan-Williams classification. Let's see that. I'll just type that here. So it's the Vaughan-Williams classification. And so class 1s would be drugs that block sodium channels. Class 2 are ones that interfere with the sympathetic nervous system. Class 3 increase the effective refractory period. Class 4 is the calcium channel blockers. And then, like with every classification, there's sort of a miscellaneous chapter or miscellaneous group that's after that. So we're going to look at these from a standpoint of basically through each one of their mechanisms, and talk about what they do and what to expect. And so what I figure we'll probably get through The first two is what I anticipate we'll get through, and then we're going to break for lunch. And before we break for lunch, you guys will take your little quiz, and then you got the videos. And then when you come back from lunch, we will go over the quiz like we did earlier. All right. So one of the things is that many of these antiarrhythmic drugs, what we want is the SA node should be the dominant pacemaker. You guys should possibly remember that from a few weeks ago, several weeks ago, maybe even a few months ago. So typically, the SA node should be the pacemaker, and we get an arrhythmia sometimes when either these ectopic pacemakers, these aberrant pacemakers, start firing faster than the SA node, or something happens to the SA node, and so some other pacemaker other than the SA node picks up. So the antiarrhythmic drugs tend to act on tissues that are aberrantly firing. Those tissues tend to be more susceptible to the drugs. Excuse me. Many of these drugs are, like I said, are cardiac depressants, and so they tend to reduce the conduction and the excitability of tissue that tends to be more rapidly depolarized or more aberrantly depolarized. And so they tend to hit the sodium and calcium channels in the depolarized tissue. So we do have a degree of susceptibility to aberrant tissue. We also see that these drugs will increase the effective refractory period more in depolarized tissue than in the normal tissue. And the same thing with calcium blockers. They tend to have a greater affinity for the activated channels, and the channels that are resting, they have less of it. So this is just sort of a background. Don't get caught up in it because it's not in red. And the same thing is we refer to this as a state-dependent action. So basically, during a tachycardia, you've got a lot of calcium channels that are being activated and inactivated per unit of time. Whereas and that's what the calcium channel blockers tend to affect more. And then when we have a loss of resting potential, what we've got is a lot of inactivated channels during rest. So basically, the channels that seem to be more activated or inactivated are more susceptible to this. So, so the channels that are being used more frequently or staying in an inactivated state are more susceptible to this. What this basically is saying is the aberrant tissue tends to be available or tends to be more susceptible to most of these drugs. So during reentry, we've got a lot of unblocked channels, and the ERP is increased, and so these channels are more susceptible. So several slides that give you some background. And also, when we have increased automaticity, so that the pacemakers seem to be firing, or another vessel, or excuse me, not vessel, another part of the heart seems to be firing more rapidly, that these antiarrhythmic drugs tend to suppress that, okay? They tend to stabilize the membrane, and they tend to sort of move that slope of phase 4 back to where it is. And some of this will be a little bit more apparent when you watch the antiarrhythmic drug mechanism of action video. So let's talk about the first group of drugs, class 1, okay? So the class 1 antiarrhythmics, we classify them as sodium channel blockade. Another way to think about this is these drugs tend to have local anesthetic effects. When you block the sodium channel, the sodium channels, that's the same thing the local anesthetic does. So the big thing about class 1 is their prominent action appears to be sodium channel blockade, okay? That is going to be the biggest issue. All right, so we have, there's like 3 different classes of these, subclasses, I should say. I don't care that you know these. Basically, electrophysiologists, electrocardiologists this is a big area they get into. That's where they make their big bucks, and you're not going to be having to differentiate it. But you need to know basically that these are sodium channel blockers and have a local anesthetic effect. But for example, the subclass A, what we see is the action potential duration gets prolonged, and the drug, compared to the other, dissociates from the channel at an intermediate rate. Class B, or subclass B. It doesn't affect the action potential depolarization, but it will not, it binds to the channel and releases pretty quick, so it's got a very rapid dissociation. And then C has a minimal effect. So there's some subtle differences in these drugs that basically account for their particular actions. When you look at the drugs, and I'm not going to again ask you to differentiate as to whether they're class 1A, 1B, or 1C, but these antiarrhythmic drugs, which we're going to use as the prototypes, we have a drug called quinidine, fairly commonly used. We have a drug called procainamide, and we have a drug called lidocaine. Okay, so quinidine, procainamide, and lidocaine, all of these tend to have local anesthetic properties. Let's see if I had one in class 1C. I didn't require you to pick up class 1C. Okay, some of these drugs, like in class 1C, one of the things with lidocaine is we didn't have an oral lidocaine. It's not effective orally. So some of these other drugs, I think mixeltine and the flecainide, these are drugs that were orally effective, I believe, if I remember correctly. But quinidine, procainamide, and lidocaine are all considered class 1 agents. They all are common in blocking the sodium channel. They all have some degree of local anesthetic actions. And if you think about it, when you have an arrhythmia and the tissue is firing too rapidly or anything, what you're going to do is if you put a local anesthetic on it, that's going to sort of numb the tissue, which is going to sort of decrease. What does a local anesthetic do? Is it basically, when you've got pain, you've got a lot of things firing, and so it numbs it by decreasing the firing, okay? So these drugs are going to basically act as a local anesthetic. They block the sodium channel and produce the effect that we anticipate, okay? Slow down. So they are good for tachycardias and good for atrial fibrillation. Lidocaine we use a lot of times when we're treating someone that may have ventricular tachycardia after a heart attack. So these drugs are sodium channel blockers, local anesthetic type actions, and they tend to be cardiodepressants. Now, this will be the last class we'll cover before we break for lunch. So the second class is beta blocking drugs, okay? You've heard of propranolol. We talked about it. Two other antiarrhythmic drugs that are primarily, these are not used for hypertension, but these are used as antiarrhythmic drugs. These are esmolol and sotalol. So all three of these, their main mechanism of action is going to be beta blockade. We will use we use these drugs when anybody has excessive beta blockade causing, so for example, if we've got excessive stimulation of the heart due to the, let's say the sympathetic nervous system is overactive, we will use these drugs, these beta blockers, to block that, okay? So what they will do is their tendency is to slow down cardiac conduction. And typically this is secondary to beta stimulation through the autonomic nervous system, okay? So they're beta blocking drugs, that's their main action. Now, some of these actions, for example, propranolol also has some local anesthetic actions. So it's predominantly acting as a class 2 drug, but it also can act as it does have some class 1 properties. And we see this with a lot of these drugs is that they will have more than one action. They'll have a prominent action, and then they will have one that is less prominent. And so that's what we see with regard to these drugs. So class 1 is local anesthetic. Think of lidocaine, procainamide, quinidine is a little bit different. And then we have the beta blocking drugs, which are propranolol is a good example, but esmolol and sotalol are also used. Many times these drugs may be used IV initially, and then we may may have them, ideally if we want to find out what's causing the excessive beta stimulation, and if we can eliminate that, then that works. But if we can't, we can put them on propranolol for a while. And so that's some of the drugs, I think sotalol or esmolol can prolong the action potential, which is what we'll talk about when we get back from lunch, which is class 3 drugs. So we've covered the class 1, the class 2. What we have to cover the rest of the afternoon when we come back from lunch is we've got 2 more antiarrhythmic drugs, and then in general the side effects of these drugs. And then we'll talk about the pulmonary drugs, and that will complete us for today. Does anybody have any questions about what we've covered this morning? Anything dealing with the cholesterol drugs, anything dealing with the inotropic drugs, or the first part of the antiarrhythmic drugs? Okay. So Marissa, I sent you a video. If you got it, if you would make sure that's posted for them for lunch. And then you can put up this morning's first questions. When we get back this afternoon, we'll go over the answers. And then, and she's already been efficient as she normally is. So the videos are posted. There's 3 videos. I think they will take you maybe 15, 20 minutes maximum to look at them. One of them will talk about the antiarrhythmic drugs, and it'll talk about class 3 and 4, which we haven't covered yet. So if you'll go ahead and give them their 4-question quiz for this morning, I will see the rest of you guys at 1 o'clock this afternoon. Hope you have a good lunch.